Good morning, everyone. At the outset, I would like to thank Dr. Radhakrishnan, Dr. Sajeesh, Dr. Suneel PR, and the organizing team of ISA Kerala for giving me this opportunity. I would thank the chairperson, Dr. Sobha, and Dr. Sathyaprakash for the introduction. And the next 35 minutes, we'll talk about a problem-based learning and discussion, which will be on one lung anesthesia. I'll have a disclaimer that this is such a vast topic and we cannot comprehensively cover all aspects of thoracic anesthesia. So we'll be highlighting certain salient points or concepts, which I will divide as preoperative challenges, intraoperative challenges, and postoperative analgesia. The case which is given to me is a 32-year-old woman who had a history of pneumonia and left lower lobe consolidation, which has changed into a cavitating lung abscess. So because of her symptoms, she has refused physiotherapy and the postural drainage. She has had significant weight loss and her current height is 152 centimeters. The imaging done shows that there is opacity in the left lower zone with a fluid level suggesting of an abscess, and CT scan confirms suppurative lung disease with cavity formation. So the bronchoalveolar washings had shown a Pseudomonas aeruginosa, which is responsive to antibiotics, and she continues to have hemoptysis. So she's now posted for a left lower lobectomy for localized bronchiectasis or pulmonary sequestration. So the concerns in this case are she's a non-smoker. There is hemoptysis and bronchiectasis, and the amount of secretion per blood is less than 150 ml per day, so that I will accept. There is anemia. Hemoglobin is 8 gram per deciliter. We have started her on hematinics. Her dyspnea on exertion is a concern. Her effort tolerance currently is about a flight of stairs, and we have involved the rehabilitation team who is doing the education bar physiotherapy. Currently, there is no active infection because she has responded to the antibiotics. The total count and differential counts are within normal. And she's on incentive spirometry, bronchodilators, and we are doing local as well as systemic hydration. Albumin is 3 gram per deciliter. The nutritional is confirmed, and oral nutrition program has been initiated. So this brings us to the first major concept, that is enhanced recovery after thoracic surgery. So we all know that enhanced recovery concept or ERAS concept has been there for the last almost 20 years, and which started as 20 evidence-based interventions, which were divided as preoperative, intraoperative, and postoperative phase. So the prime concept or a physiology in the ERAS pathway is to reduce the surgical stress so that the patient has a better perioperative course and recovery. So the preoperative course, as all of us will agree that anesthesiologist has a great role to play in the ERAS. So in the preoperative phase, a lot of emphasis is on patient education and counseling, and pre-optimization. The risk assessment has to be done properly, and smoking cessation whenever possible should be done for about a period of 8 weeks. There is a lot of emphasis on reducing the fasting period. So we have moved away, or we rather insist that the patient takes glucose containing fluids 2 hours before surgery. Antibiotic prophylaxis should be given at least 30 minutes before the surgical incision, and thromboprophylaxis has to be administered. Among the intraoperative interventions, the most important thing is a minimally invasive surgical approach. And we need to titrate our anesthetic so that we match the surgeons in terms of the minimally invasive approach. So a lot of times there is an emphasis on balanced anesthesia, maintenance of temperature, avoiding sodium and water overload, and protective lung ventilation strategy, which I will come upon later in the acute lung injury prevention stage. And excellent analgesia. Thoracic epidural still has a lot of advantage, but in sometimes when you have infective pathology like this, certain surgeons don't prefer. So you can go for a thoracic paravertebral. Post-op phase, entire post-op concept is based on excellent analgesia, which will facilitate the patient to do early ambulation, early physiotherapy, and the drains can come out and patient can go back to their oral nutrition and better recovery. So there is another concept which has come, that is pulmonary prehabilitation. I have written rehabilitation, but it is prehabilitation. Again, this is a multidisciplinary approach which is quite similar with the IRAS concept. So this concept basically is aimed to improve the functional status. When you improve the functional status, it improves the candidacy. That means a patient whom we have thought previously as not resectable or not fit for surgery can become candidates for surgery. So it has been of proven evidence in COPD and lung volume reduction surgery and lung transplant surgeries. And there's a how they do it is either with an endurance training or a high intensity interval training. The ideal period is about 4 to 8 weeks, but sometimes it's not possible, especially when you're dealing with malignancy. So the next question which all of us would like to ask is whether she will tolerate the proposed resection. So here I will show how I have taught during my post-graduation, and now I have changed. So the preoperative FEV1 is 60%. The proposed surgery is left lower lobectomy. So the predicted post-op FEV1, if you remove this particular lung, that is left lower lobe, that is 10 out of 42, will come as 45.7. So we will accept, okay, this patient will tolerate. And we will discuss the analgesic option. We discussed thoracic epidural and multimodal analgesia. The patient has agreed for that. The next question is, how do you decide on the size of the tube? So we will normally follow the sex and the height criteria. Because her height is 152 centimeters, we normally look at Hanela's methods. That is, we look at the left main bronchus diameter at 1 cut below the carina. So her cut was 10 centimeters. So we decided to go for a 35 left double lumen tube. So this is from the Peter Slinger textbook. So after you do the initial assessment, you need to go back and review the initial assessment results. Assess the difficulty in lung isolation. So in the chest imaging, we didn't anticipate any difficulty. And you have to assess the hypoxia, which I will discuss later in the hypoxia part. So one foremost question which comes to everybody's mind is, why do we do this pre-pulmonary evaluation? Obviously, this is for risk assessment and also for risk reduction, because we have to do certain intervention to reduce the risk. So why we are worried is because of the postoperative pulmonary complication and the associated morbidity and mortality. So only with the advent of pulmonary function tests, we could quantify and say that, okay, an abnormal FEV even less than 60% is the reason why we have a lot of problem. So we'll try to address certain concepts which we all are following a few years back. So previously we used to say that an FEV1 of more than 2 liter is good for pneumonectomy, and more than 1.5 liter is good for lobectomy. But we know that FEV1 depends on the race, age, sex, height of the patient. So if you look at this particular picture, a 50-year-old male who is 180 centimeter tall has a FEV1 of 3.4 is only 59% of predicted. But for a female of the same age, 160 centimeter tall, 2.3 liters is equal to 87. So this clearly says that absolute value doesn't have doesn't have great value. And if you look at all the studies, when you compared absolute values with versus FEV1 and DLCU expressed as percentage predicted, it is very clearly shown that all these outcomes are related to percentage predicted values. Okay, and when you look at percentage predicted values, it is not the pre-value, that is 60.7 we need to look at. We need to look at the best post bronchodilator value, that is 62.3. So that is the first concept I need to change. But it was very clear that we could attribute only 20% of all the morbidity or mortality to an abnormal FEV1. So the search or the quest was there for another determinant, and that took us to DLCO. So we all know that if you even looks at the lung mechanics, and the lung parenchymal functions are assessed by DLCO. And a predicted PO post of DLCO of less than 60% is associated with significant morbidity and mortality. But what is important here is the correlation between FEV1 and DLCO is consistently poor. So if you look at the 3-leg stool, which all of us use, but we need to remember that this was primarily designed for malignancies. So the third important component of that is VO2 max. So we need to have a VO2 max of at least 15 ml per kg per minute to say that this patient has good enough effort tolerance. So if you look at surrogate markers, that is stair climb test of more than 2 flights and 6-minute walk test. And there should not be no excessive desaturation of more than 4%. ABG, most of us would like to document, but absolute values of PCO2 do not correlate with outcomes. Generally, PCO2 of more than 50 is considered as a contraindication for lung resection. And if there is hypoxia or oxygen desaturation, that is more important. So now we'll try to go into the concept of estimation of predicted post-op FEV1 and DLCO. So I have told that we need to go for a percentage predicted value rather than absolute value. Second thing also we have covered, we need to go for the best measured post-bronchodilator value. The third part is that we need to look at only the number of functional or unobstructed lung segments removed. And we need to calculate the total number of functional segments. Okay, so if you're talking about segments, we are talking about 19 segments, and if you're talking about subsegments, we are talking about 42. And this everybody knows. I will not go into the details. So we'll look at a different scenario now. You have a 50-year-old man with a history of TB, but here you have the entire left lobe destroyed. But he has good effort tolerance, probably because the right lung has undergone a compensatory hyperinflation, and he's posted for left pneumonectomy. So if you calculate that 1 minus 20 by 42 into pre-op FEV1, you will get about 28.8%. So you may wonder, okay, whether this patient will tolerate, or should I be taking him through this pathway? But any of us who have been doing thoracic anesthesia knows that this patient will tolerate the resection very good. So if you look at the recommendation says that for any resection more than lobectomy, you need to ideally do a perfusion scan or a radionuclide scan. So you can do either a ventilation scan or a perfusion scan. Most of the centers do a perfusion scan. So how do you use a perfusion scan? So you need to multiply the pre-op FEV1 into 1 minus the fraction of total perfusion to the resected lung, same for DLCO. So when you do a perfusion scan, we realize that only 20% of the blood is going to this side, 80% is going to this side. Okay, so 80 into 55 will be 42%. So this person will easily tolerate the resection. Okay, so now we'll come to the third part, that is exercise testing. So the aim of the exercise test is to stress the whole cardiopulmonary or the systemic oxygen delivery system to estimate the physiological reserve. Okay, so VO2 max is shown to predict complication. So I'll give you an analogy here. So if you have an old Maruti 800, it is good enough to drive in and around Trivandrum. The moment you have to go for a tour up the hills to Pulmonary or something, we will make sure that we service it, make sure that brakes are good and everything, or service the engine and then take it. So this is exactly the importance of rehabilitation, or importance of knowing the systemic reserve. Okay, will this car or our body take this stress? So we'll look at certain evidence. So if you look at this study, which was done in 2005, they had about 100 patients who underwent lung cancer surgery. 4 died, 21 had post-op complications. So you can see that those with no post-op complication had an FEV1 of 2.1, and those with complication had an FEV1 of 2 liters. So you will say that, okay, that is good. But all of us know that this doesn't have any significance. So we looked at the VO2 max. So the guys who didn't have perioperative complication had a very good VO2 max compared to the guys without with complications. So rather, VO2 max is an important determinant. So what is more important is to understand that a resting PFT, whether it is if you even DLCO or like when you do a normal echo at rest, it can be normal. Okay, ejection fraction will look like normal, but the system failure occurs when the system, that is muscle, cardiovascular system, and the pulmonary system is under stress, like surgery. So the second part why we need to worry about exercise test is that somebody who with a borderline FEV1 and DLCO, we can decide whether this patient is a candidate for surgery. So that forms the basis of current recommendation. So if you ask the patient whether he can climb about 3 flights of stairs, that identifies a patient who is at low risk of perioperative complication following lobectomy. Okay. And it's ideal to have a handle pulse oximeter and look at the exercise desaturation. So the thing which has changed significantly in the last 8 or 9 years is the ACCP guidelines, which we have not adopted so much into our practice, but I think this is a wonderful recommendation. So if somebody has a high risk cardiac evaluation, you need to send him for a CPET. If the predicted post-op FEV1 or DLC is less than 30%, yes. However, if it is in the in-between stage, 30 to 60%, you need to subject them to a stair climb test or a shuttle walk test. If the stair climb test is less than 22 meters or shuttle walk test is less than 400, then again, you need to send for CPET. So when you send for a CPET, you can have a VO2 max less than 10 ml per kg per minute, or 10 to 20 ml or more than 20 ml. So if it is more than 20 ml per kg or 75%, then it is a low risk. And if it is less than 10 ml per kg per minute or less than 35%, it is a high risk. Some remaining one is intermediate risk. So what do you mean by a low risk? So when you say low risk, the expected mortality is below 1%. Intermediate is about 1 to 10%, but the benefit of surgery is considered to be outweighing the risk. High risk means there is more than 10% risk with the standard anatomic resection. So this is some area where patient should be counseled for an alternate surgical approach or sublobar resection or minimally invasive approach or a non-surgical approach depending on the comorbidity. All of us will agree that sometimes we have patients with significant cardiac comorbidities. So there is something called a thoracic RCRA, which came out in 2010. If there is a history of CAD, CVD, serum creatinine more than 2, and if the patient is coming for pneumonectomy, look at the total score, and if it's more than 2, we need to optimize the cardiac function according to ACC-AHA recommendation. So now with that history or knowledge, we'll go back to another patient. So this patient is a 21-year-old ASA1 patient who has an effort tolerance of 2 flights, and she had carcinoid of the left main bronchus. Debulking done, but because of recurrence, she was advised left pneumonectomy. So this is the X-ray. You can see that the right lung has done compensatory expansion. But when we did the CT, you can see the left upper lobe is totally gone. Left lower lobe is aerated, even though there is volume loss. If you look at the pre-op FEV1, it was 44% predicted, which was slightly worrying. So we calculated the predicted post-op FEV1. So if you use the first formula, which I said, a 19 minus 9 for a pneumonectomy or a 42 minus 20, we are getting a low predicted post-op FEV1. But we need to, as I said, we need to calculate the functional segments. The left upper lobe is non-functional. That is 4 segments are out. So the total number of functional segments are not 19, but only 15. And the number of functional segments to be removed are 5, only the left lower lobe. So the predicted post-op FEV1 will be 29.33, which is just about borderline. Okay. So we looked at the VO2 max, which came as 17.9. I said that if it is 35 to 70, it is intermediate risk. So we accepted the patient, we gave her epidural, and we had this one. So another important concept, which is important for us to understand, is does PFTs actually predict outcome? Or is there a correlation between the predicted post-op FEV1 and what we measure in the intermediate post-op period? So what is very important is the actual measured post-op FEV1 is less than the predicted one, and there was an inverse correlation with pain. So this brings us a very important question that as anesthesiologists, we need to provide excellent post-op analgesia for them to function, and we need to provide optimum lung isolation, and we need to give lung protective ventilation so that the lung function is not compromised postoperatively. The surgeon should do a muscle sparing thoracotomy, protection of ICN, intercostal nerve, by maybe drilling a hole in the lower lip rather than entrapping it, and use VATS whenever possible. So there is a significant role of minimally invasive surgery, and especially in patients with marginal lung function. So another area which is there in the topic is lung volume reduction surgery, which is have to do for emphysematous lung disease. So their pre-op lung functions are quite bad, and the pre-op FEV1 in this particular patient was 40, and after the surgery, about 3 months, when we looked at it, it was 55%. He had a bilateral VATS. So how did the FEV1 increase? So these patients actually benefit from the resection of a hyperinflated lung. So when you have COPD, when you take out a non-functional or a hyperinflated lung, the remaining lung can expand. So this is sustained even from the immediate surgery to up to 6 months. So this is the LVRS effect. Okay, so if you are able to provide them a minimally invasive surgery and good analgesia, they will do well. What is important for us to understand is, when you have patients with lung malignancies, the in-hospital mortality we are worried about is 2 to 4% for lobectomy and 6 to 8% for pneumonectomy. So, but if you say that the patient is at high risk or borderline lung function, and if you deny them surgery, the non-surgical mortality is 100%. So the fitness for surgery should be very carefully thought after, okay, and it should be always multidisciplinary. This takes us to the next part, that is hypoxia during one lung ventilation, which is defined as a saturation of less than 90 or a PaO2 of less than 60. The incidence is about 1 to 10%, but in the pre-fiber optic era, it was like 38% because of the malpositions. And the other factors which are implicated are lack of recognition of the tracheobronchial anatomy and lack of skills with the fiber optic. So obviously, the most important measure to manage is prevention. So correct position of the double lumen tube, clinical confirmation, airway pressures, as well as FOB. Appropriate ventilation strategies, and identifying the patients who's at risk and plan appropriately. When I talk about airway pressures, if you have a patient whom you have introduced double lumen tube, okay, so once you do the two lung ventilation, look at the airway pressures, and we are trying to with a volume controlled ventilation. Say you are giving for a 50 kg man or a 60 kg man, you are giving about 300 ml tidal volume, and you try to isolate. If you isolate the lung by clamping, say the right side, and the airway pressure shoots up to say 40, you need to understand that this tube is not in the correct position. So that should give you the first indication that this thing. However, if it is gone from 20 to 25, then you may shift to pressure control. You may be able to ventilate this patient with a low plateau pressures and achieve about 5 ml per kg tidal volume. So that is this thing. So pay attention to the details. So FOB obviously is the gold standard. When you go through the, if you put a left DLT, you should be able to see the primary carina, blue curve distal to the carina. And if you go through the bronchial lumen, you should be seeing the left upper lobe as well as lower lobe. On the right side, we need to align the right upper lobe takeoff with the slot on the right DLT, and you should be seeing the trifurcation. So it is important to understand who is at risk. So there are patient risk factors where somebody with a previous contralateral lung resection, somebody with a normal FEV1, something like somebody who's undergoing one lung ventilation for esophagus. He may be having an absolutely normal lung. So if you try to collapse that lung completely, especially the right lung, they collapse, they will have hypoxia. Somebody with a chronic vasodilator therapy who will lose the hypoxipulmonary vasoconstriction effect. Poor two lung ventilation, that is common sense. And right-sided surgery, because you're going to collapse the lung with more blood supply. If you do a thoracotomy in supine position, yes, vasodilator use, and excessive volatile anesthetic more than a MAC, again because of the same reasons, that is obliteration of hypoxipulmonary vasoconstriction. So If you have hypoxia, which is defined as a saturation of less than 90, first and foremost thing you need to do is increase the FiO2. A good communication here is very crucial. So if there is non-life-threatening hypoxia, that is saturation is hovering about 90, 92 or 94, you can continue the one lung ventilation, but probably call for help because if your senior is not in the theater. So in the meantime, you can look for treatable causes. So first and foremost is the DLT malposition, or if there is secretion or blood. So a lot of us don't have the luxury of keeping a double lumen, fiber optic in the theater. So you ask your technician to bring the FOV. In the meantime, do a suction and make sure that there is no secretion or blood, which is hampering your ventilation. As soon as the fiber optic comes, you can check the DLT position. And in the meantime, look for other correctable causes like a low blood pressure. So if you have low blood pressure, low cardiac output, that means more oxygen extraction happening at the tissue level, more deoxygenated blood coming back to the heart. Too much depth of anesthesia, which can impair the cardiac output and RV function. Blood loss, so check for anemia and RV dysfunction. This is especially important for COPD patients and somebody with a coronary artery disease. Improving the oxygenation can be done by optimizing ventilation and optimizing perfusion. This can be divided into what we can do on the non-ventilated side. So we don't go straight into the non-ventilated side, because especially when the surgeon is doing a VATS. So what we try to do is we will do a bit of recruitment maneuver of the ventilated lung, optimize the PEEP, and make sure that there is no intrinsic PEEP. If you give too much of PEEP, what will happen is we will push the blood back to the non-ventilated lung, because too much of PEEP will shunt the blood back. So that is something which we don't want. If it is not working, what we can do is we can tell the surgeon that I need to gently re-expand the lung, okay, and then start a CPAP. Ideally, we should use with a commercial CPAP device, or you can use 1 to 2 liter flow and connect a HEPA filter and do intermittent occlusion once in about 6 to 8 seconds. How do you optimize perfusion? So one is decreasing the shunt. So one option is IV almetrin. There is a possibility, but we don't use it on a routine basis. But if what surgeons can do is, the surgeon can do compression that will augment the HPV. If the surgeon is planning a pneumonectomy, you can do a early pulmonary artery clamping. So other option is to improve the ventilation, ventilated lung perfusion. So you, as I said earlier, to achieve the ventilation tidal volume with a lower pressure. So I prefer to use a pressure controlled ventilation. Other option is inhaled nitric oxide. But what we need to understand is you need to have a separate machine ventilator or a device which can give inhaled nitric oxide, and it is costly also. So the other things which you can think is inhalational versus TIVA. There is no great advantage between both, but I will prefer inhalational because of its beneficial effects in acute lung injury prevention. Between PCV and VCV, there is no evidence, but I am a proponent of pressure controlled ventilation because I always feel that with a pressure controlled ventilation and maybe 1:1.5, I can get a achieve the desired tidal volume with a lower plateau pressure. So high tidal volume is very good for oxygenation, but we always try to do with lower tidal volumes and PEEP to prevent de-recruitment. So I have talked about protective lung ventilation. We have moved away from the traditional concepts to an FiO2 of 0.5 to 0.8 and accepting a saturation of about 90. I accept this 6 ml per kg tidal volume and accept 40 to 60 PCO2, but make sure that it doesn't go more than 70 because there can be a gradient between end-tidal as well as arterial CO2. PEEP, again, titrate, look at the auto PEEP and ventilator mode, pressure regulator. And if you want to maintain oxygenation, one option is high frequency jet ventilation, which will not impair with surgical visualization. So when we talk about hypoxia, this discussion will not be complete if we don't talk about malpositions. So all of us have studied that the three malpositions are too deep, too out, and has gone into the opposite side. And the effects are hypoxia, which we have discussed, high airway pressure, loss of isolation, and lung failing to collapse. So we'll just go for this pictorial representation. So left, we are talking only about left DLT. So this case, left DLT has gone 2 in. Okay, so in here, if you notice that the airway pressure, this again we are talking only about left-sided lung surgery, and we have put a left DLT. So if you try to ventilate, we are not going to get very high airway pressures, but the surgeon may notice that the left upper lobe is not collapsing. But if you're trying to ventilate with the left side, okay, and the right lung is collapsed during the tracheal clamping, you will feel that the airway pressures are on the higher side. Okay, so a next stage is when you are pushing a bit too in, where this lumen is also inside. So here, left upper lobe will not collapse, but more importantly, when you try to inflate the bronchial cuff, you will struggle to do the ventilation. Okay, so there you can anticipate high airway pressure, but this high airway pressure you will detect immediately after inflating the bronchial cuff, and you will understand there is a malposition, and you will correct it with the help of a fiber optic. If you don't do that, we'll have desaturation. So these are the problems when the DLT is too in. So if the DLT comes out mostly during surgical manipulation, you can imagine you're doing this surgery where you have suppurated lung disease. Surgeon has manipulated, DLT has come out. What will happen? All the muck which is here will go into the right side. So there is loss of lung isolation, then contamination of this side. This ventilation which is coming from the tracheal lumen will go to both sides, lung will expand. So surgeons will get upset, and even he will become more upset when he knows that there is contamination of the other side. And if there is spasm, you can have desaturation also. What we need to do is you do a thorough suction, especially of this side under fiber optic, and deflate this cuff as well and reposition it. But a much more dramatic situation happen in a slightly more smaller patient when this happens. So if you put too much air and into the bronchial cuff and it slips out, suddenly a junior may call you to say that, okay, sir, I am not able to ventilate. There is no ETCO2, bag is very tight. Okay, so what you need to do immediately is deflate the bronchial cuff. So then you will lose, anyway you have lost the lung isolation, but you will be able to ventilate either one lung or both lung. In this patient, both lung, but in here, you will be able to ventilate one lung. Okay. So the third scenario is left DLT slipping and going to the other side. Again, there is loss of isolation because there is contamination. You will inflate the left side, so there is lung will re-expand, and there will be high airway pressure because you will not be ventilating the right upper lobe. Okay. So when you have a high airway pressure, we need to think about malposition, secretion, and blood, which we need to sort out. And one thing we should not forget is you can have a pneumothorax on the opposite side, especially when you're doing with bullous lung disease. Okay, so the common scenarios during a left thoracotomy are this and this, which we have discussed. So when you have a problem, rule out the secretions and blood. Make sure look at the ETCO2 and look at the bronchospasm, and deflate the bronchial cuff, which will sort out the ventilation of one lung or both lungs. Pass a bronchoscope through the bronchial lumen. If you see the carena, it is too out, deflate it and advance. If you cannot visualize carena, then you withdraw till you see the carena and then isolate isolation. So I will not go into the further details because of the lack of time. The next part is acute lung injury. Now that hypoxia during one lung ventilation is not a major problem. We have to think about ALI. The incidence is about 2.5 to 3.1 in lung resections, and it is much higher. That is about 10% after pneumonectomy. Okay, so that's about 1 in 10 patients. So we commonly call it as post-pneumonectomy pulmonary edema, and the importance is it has got 25 to 40% mortality. So there are certain mechanisms which I will not cover, but there are certain risk factors we need to understand. Patient risk factors are poor predicted post-op lung function, pre-existing lung injury, chemotherapy, infection, trauma, alcohol, and a female gender. Procedure time: prolonged one lung ventilation more than 100 minutes, larger resection, esophagectomy, transfusion, large perioperative fluid, and lung transplant. So how we can attenuate: limiting the duration of two lung ventilation, protective lung ventilation strategy, pressure control ventilation, inhalational anesthesia. That is why I said I will prefer inhalation more than TIVA, and hypoxic reinflation. When the surgeon tells you to reinflate, use a mixture of air and oxygen. So fluid management thoracotomy is important because of the same thing. Follow the IRAS protocol, and if you're using an epidural or a regional technique, if you have hypotension, don't hesitate to add a bit of noradrenaline to maintain, or a phenylephrine infusion to maintain the pressures. Fluid balance is important because if both hypovolemia and hypervolemia are bad, so there is no need to give third space fluid. Generally follow restricted regime. Use colloids appropriately. Fluid balance in the first 24 hours not more than 20 ml per kg, and no need to maintain a urine output of 0.5 ml, more than 0.5 ml per kg. And whenever possible, use goal-directed therapy. Coming to my last slide, about post-op analgesia, still thoracic epidural or thoracic paravertebral are the gold standards. We in our hospital either give thoracic epidural or thoracic paravertebral single shot, rarely catheter, followed by fentanyl, magnesium, ketamine, PCA, and paracetamol. We try to avoid NSAIDs in elderly patients. For VATS, we either give a thoracic paravertebral or erect spine catheter. So to summarize, IRAS has a definitive role in optimizing the outcome of thoracic surgical cases, and anesthesiologists, we should start involving in the preoperative period. You should use the ACCP guidelines, assess the cardiopulmonary reserve. Whenever possible, use rehabilitation. And the intro management, we need to focus on analgesia, ALI prevention, and the surgeon should be able to do MIS. So with this, we can manage these sick patients optimally. Thank you so much.
Thank you, Dr. Raj. Am I audible? Am I audible? Dr. Sathyaprakash?
Yes, madam. Yes, madam. I'm hearing you.
Madam. Okay. Okay, that was a very informative talk by Dr. Raj. Thank you, Dr. Raj. He has given 3 different scenarios and given different aspects for the clinically important aspects of anesthesia for lung volume reduction surgery. As he has already said, the risk stratification and optimization all depends on the underlying pathology. It all differs from case to case. So, Dr. Sathyaprakash, have you got anything to add, sir?
Madam, first of all, I thank the Kerala State ISA branch for having organized such a nice function and given me this opportunity to chair a session. And I also would like to thank Dr. Raj Sahajanand for the beautiful presentation. His presentation has been very practical, less of theory, more of practical points, and more of problem shooting management of the patient who has come for thoracic anesthesia. Thoracic anesthesia, as you all know, is a field, which very few people are practicing in anesthesia. It's, this probably because of the very few surgeons we have, thoracic surgeons. We have a lot of cardiac and vascular, but very few thoracic surgeons. And of course, this is one of the new upcoming topics. And people are coming to this, this one, because we're getting more number of cases with a lot of thoracic diseases. First of all, I would like to ask Dr. Sahajanand one small point about the role of preoperative fiber optic bronchoscopy in preparation of this patient for surgery.
So, I agree completely with you, especially when you're dealing with malignancies. The CT scan gives a good indication about any kind of endobronchial involvement. But the surgeons, if you have any doubt, we definitely put in a single lumen tube initially, make an assessment, and then plan. Because if you have any kind of luminal infiltration, it can affect your choice of one lung ventilation also.
More than that, so the first case that you are talking about, the lung abscess, somehow in our institution, we would always, I do the bronchoscopy regularly. We always post them at least for 2 to 3 occasions for a bronchoscopy to clear the secretions, because these are all morbidly diseased patients who will not be able to bring out secretions. There will be a lot of secretion. So generally what we do is we have 2 or 3 sessions of fiber optic bronchoscopy to clear secretions. So that really helps. I mean, we bring out, it aids in the removal of secretions. And secondly is, I think all of us who are practicing thoracic anesthesia should be well versed in fiber optic bronchoscopy, because it goes a long way during the procedure and after the procedure also. Especially in the intraoperative phase for the assessment of the tube, like you have rightly told, the positioning, everybody should become proficient in the use of fiber optic bronchoscope and handling of the airway.
I agree completely with you, sir, because you need to go well beyond the carina and understand then only you can do a complete lavage as you suggested.
Yes, sir. My next other small question was, when you're introducing a double lumen tube, sir, do you introduce it with the stellate or do you remove the stellate after you pass the vocal cord? That was the practical question I wanted to ask.
Okay, so in our center, we like to take the stellate out after we negotiate the vocal cord, because you don't want to produce iatrogenic injury. But however, there are proponents of using the stellate also. My personal preference is to remove the stellate.
Okay, so I slightly differ. I would prefer to keep the stellate till the end and then remove it. That I found it more useful.
It all depends on whether we are reusing the double lumen tube also. Sometimes because of the cost constraint, we are reusing
we have been reusing the double lumen tube because it is cost constraint, and this is more of a government hospital where resources are scarce. So we are forced to reuse the double lumen tubes. And the next point you rightly pointed out is the resection of lungs in a diseased lung or in a normal lung. Especially patients coming for pneumonectomies, probably the image you showed is one of the ideal case for doing a pneumonectomy, though it looks very scary. But they do post-operatively also, they have a very normal life and they do well. So with all these points, I thank you for your beautiful presentation and highlighting all the the important points of this. One last question, sir. At what level would you introduce the thoracic epidural for analgesia?
So I will probably go at the T5, T6 level. So that will cover the incision as well as the drain site, T8.
Oh.
So T6 level should be good enough.
Generally, we do it at about the T1, T2 level. Generally, I prefer that level. So that most of the
only reason is when they put a drain, my surgeon, especially when they go for a posterolateral thoracotomy, prefers to have the drains at the T7, 8 level.
Yes.
So that to cover that one, we have come down a bit more to T5.
Yes, sir. We just push it a little down. It generally this system also works. That's what I found out. Madam, over to you, madam.
Dr. Raj, my question is, first one, will you have you ever used ketamine, preservative-free ketamine as an adjuvant for local anesthesia, local anesthetic for epidural? Preservative-free ketamine, have you ever used?
Not for thoracic, ma'am.
Okay. My second question is actually out of interest I am asking, because with extensive lung surgery and all, previously we had complications like bronchopleural fistula, bronchocutaneous fistula, like that. Now with the minimally invasive surgical procedures, what is the incidence of complications like this?
So I think a lot of things depends on your surgeon also, ma'am. Because my surgeon, we have got a exclusive thoracic surgeon.
Okay.
So our incidence is actually quite low, and we do about 400 thoracic surgeries per year. So we do at least weekly 3 days of thoracic surgery. One list is fully dedicated to that.
Okay.
So, and surgeon is also quite a senior surgeon. Our role in that particular aspect is whether we do open or closed. Once he feels that he has achieved a good resection, he will fill that thorax with saline or betadine soaked saline, and we ask us to ventilate with about 30 centimeter water airway pressure. So we try to not only achieve the airway pressure and see the leak, we try to put in a volume control mode, say with about 300 ml tidal volume, and look at the expired tidal volume. So we accept about 20% leak. Anything more than that, we'll tell them to get a bit more meticulous. So we try to get a balance. Sometimes very difficult to get an absolute seal. Yeah.
With ventilator settings and newer methods, we can avoid. I think I have seen these complications early in my PG days, I think. Okay. Anything else, sir?
No, nothing. Most of the surface leaks from the lung generally seals by themselves within the first or second post-operative day.
Yeah.
But major bronchus leak is quite rare. Having done a good surgery, the leak from the major airways are quite rare. But these problems you can expect in the post-operative phase after a long time when they come back with some infection or other things. And post-operative after, the delayed post-operative complications where they develop this bronchopleural fistula sometimes after resection.
True, sir. I think we can wind up the session. So,
thank you.
I thank all the organizers of Trivandrum City branch of ISA for having me as chairperson for this excellent session. And I wish the program all success. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you, ma'am. Thank you, Raj, sir.
Thank you.